Welcome, ladies and gentlemen, to this instruction video about the treatment of suicide risk with EMDR. My name is Kerkhof. I'm a former professor of clinical psychology in the Netherlands at the Vrije University in Amsterdam. When we think about suicidal intrusions, we are discussing the imagination of frightening anticipations. I will give you some information, some background information on suicidal intrusions, some information about the procedure of EMDR, and present you some scientific evidence about the effectiveness of EMDR in treatment in suicidal intrusions. We present you later on with a video in assessing the suicidal intrusions and the instruction of EMDR sessions. All of this is meant to improve our understanding why EMDR is so effective in treating suicidal intrusions. We start with Ringel, a former psychiatrist in Vienna, who in 1976 presented his so-called pre-suicidal syndrome, which consisted of three components. First was the tunnel vision. We all are familiar with that name. The inward aggression turned in towards the self, the madness towards itself, and the obsessive preoccupation with suicidal fantasies. He noticed that many times before people commit suicide, they tend to have visual representations of their own suicide and perhaps also of their own funeral. And it was rather often the case in highly suicidal patients. If Ringel would be alive now, he wouldn't have called it suicidal fantasies, but he would have called it suicidal intrusions. The intrusions are suicidal fantasies. These are not always, but sometimes noticed in therapy sessions, but until now it was never identified as a target for treatment. The most famous and well-known, well-used questionnaires in suicide ideation never asked about the mental imagery. There is a recent analysis of about 27 studies of Lawrence in 2023, and summed over all these research studies, she found that about 74% of all patients in clinical samples have mental imagery of their own suicide. In my own practice, since I started asking for mental imagery, I found that 100% of all suicidal patients have suicidal images or suicidal intrusions. I make a distinction between suicidal images and suicidal intrusions. The distinction is not very sharp, but suicidal images, I call these visual representations of their own future, of future suicide, preparations, executions, consequences, the funeral, etc., in which the person feels that these representations are his own voluntary choices. So it's his or her images when they contemplate their own suicide. It's voluntarily, and it's mostly not very frequent, perhaps once a week, once a month, twice a week. And suicidal intrusions are visual representations which impose themselves upon the persons involved, compulsive, frightening as horror images, and out of control. It's very repetitive, hundreds of times a week, tens of times a day, perhaps hundreds of times a day. People have the fear of losing control. What if I lose control and do something I don't want to because of these images? Central aspect of suicidal intrusions is the fear of losing control. What if? Well, there's a disaster coming to me soon. That's the basic starting of this intrusion. There's a disaster. I will be faced with a disaster soon. I don't know how to deal with this disaster. I can't prevent this disaster from happening, and suicide is the only escape for me. For example, the disaster is, I will always be lonely. I will never be treatable. I always will be depressed. I always will be alone. I always will have to face the terrible pain I can't endure any longer. I don't know how to deal with this disaster. I can't endure the pain. I will not be able to endure the future pain. So when thinking about disaster in the future and thinking about suicide as the only way of escaping this disaster, people tend to see their problems in the future and tend to see their own suicide, how they do it. And then they think they have no control about their images because these images impose upon them. And they don't have control and they have to comply. It's an urge. They have to respond to the compulsion, the obsession that these images present. I cannot bear it anymore. Then you lose control. So the characteristics of suicidal intrusions are, they contain images of future suicide and sometimes the funeral. They have incessant, visually, imaginative worrying and rumination. It's worrying, rumination in images. It's not welcome, not voluntary. It's frightening, it's heavy. People think it's uncontrollable, unescapable, anxious, powerless. And it concerns obsessive, compulsive imagination. They are disturbing, they are lively, they are clear, they are fearsome. People experience tenseness, anxiety, tension. It's self-torturing, it's overwhelming, these images. And it produces an urge to escape these images immediately, as soon as possible. And how to escape it? Whatever way. Suicide or, well, no other way is suitable. So people also say they have positive aspects of their intuitions, in positive sense that they think about ending the chaos, peace of mind finally sleeping, no longer having to feel my depression, no longer having to feel my loneliness. These are the positive aspects of the intrusions, but at the same time these positive aspects are only a representation of the negative aspects. So the positive thing is that's a final exit, which is a friend. If everything goes wrong, you always can commit suicide as a final exit, as a friend. In this process, patients become afraid of themselves. What if I always have these images? What if I always will remain depressed? What if my kids become unhappy because of my suicide? What if I make a wrong choice? What if I will be admitted to a psychiatric ward? What if I act in an impulsive manner? What if I survive my attempt as a permanently crippled person? So in the end, people think, I can't control it anymore. I cannot endure it any longer. I'm afraid I cannot control myself any longer. I cannot fight anymore with my inflictions. I don't have the energy to resist. In research among suicide attempters interviewed in hospital after a suicide attempt, we regularly find a percentage of 40% of people declaring that they attempted suicide because they didn't know. They said, well, I lost control. I don't know why I did it. I just did it. Apparently, I lost control of myself. I didn't want to do it, but I did. So people have the impression that they lost control, and that's the basic motivation for the attempted suicide. The most problematic of this is that when patients are admitted for the second or third time after suicide attempt, each time they will be reinforced by thinking, I lost control. And in preparation of the next suicidal crisis, they again will remember and will predict that they will once again lose control in the next time. So we are faced with an awful perspective. Imagine yourself a woman, a mother, depressed, 2 or 3 young children, and she has 10 times a day or 15, 20 times a day, she has images of herself when she throws herself in front of the train. She doesn't like that, she doesn't want it, but she has these intrusions. And she knows it will terribly impact her children when she commits suicide, so she doesn't want to commit suicide, but she has these intrusions all the time. And after a while she will know for sure that she will not be able to resist the temptation to throw herself in front of the train, but she doesn't want to. But she knows she can't resist their own urge anymore. So she's going to do something she doesn't want but cannot prevent it, and she commits suicide like in a Greek tragedy. So the fear of losing control is very important in a better understanding of the suicidal process. And the more depressed, the more suicidal intrusions, and vice versa. The closer to suicide, the more frequent the intrusions are. The more frequent intrusions are, the lesser control there is. And the fear of losing control leads to urges or inflictions and to suicide. So in clinical experiences in treating patients, we notice that we cannot think about suicide without having images. It's impossible to have only thoughts about suicide. Thoughts about suicide are always go together with images. Images are more imposing than thoughts, and clinicians, unfortunately, until now, clinicians seldomly ask or inquire after suicidal intrusions, and patients don't want to burden their caregivers, and many patients are ashamed to tell their thoughts. But somewhere unconsciously they know that they exaggerate the disaster. So when thinking about suicidal intrusions and losing control, I would expect that the EMDR flash-forward protocol would be suitable to treat suicidal intrusions, since this protocol aims at imaginations of future disasters in generalized anxiety syndrome or obsessive compulsive disorder. So by using eye movements and imaginary confrontation with the horror image of the feared disaster or feared suicide, the working memory is heavily taxated or burdened so that the anxious involvement with the horror image will be neutralized. That's the theory about EMDR. So about 2010 I started to think that EMDR would be effective in treating suicidal intrusions as a flash forward. I started experimenting with real patients in my outpatient private practice, and I treated about 70 patients with EMDR for suicidal intrusions, and only one did not respond positively to this treatment. We organized a grant for a randomized clinical trial, and it has been conducted, and the results are now published. The study is called the Symmetry Study, and these were the inclusion criteria. They were 18 years of age, of course. They had to have suicidal ideation, depressive symptoms, and suicidal imagery, so they had to have thoughts about it. That was for the inclusion criteria for the experiment. For a previous phase for assessment, they didn't need to have suicidal imagery, but depressive symptom and suicidal ideation. Exclusion criteria were psychotic disorder, bipolar disorder, and complex PTSD, since the risk was high that in complex PTSD these patients would have had other EMDR treatments for flashbacks. So first we had the intrusion interview. When there were suicidal intrusions, people were randomized, 46 to the condition of EMDR on top of treatment as usual, and 45 to treatment as usual only, and follow-up measures every 3 months. So out of these 178 depressive suicidal outpatients in the study, 158 had suicidal imagery. Only 13 considered their suicidal image to be not to be intrusive. Therefore, out of these 178 depressed suicidal outpatients, 145 had suicidal intrusions. That means that this is a truly representative sample for outpatients in the psychiatric clinic. This means that we can assume that at least 4 out of 5 suicidal patients indeed have suicidal intrusions. So the results are as follows. We saw that there was a huge difference between the decrease in suicidal intrusions and the frequency and intensity in the experimental group compared to the control group. This is quite a big difference. You nearly never see such a big difference, such a marvelous result within psychotherapy studies. If you look at suicidal ideation, this is the verbal suicidal ideation, this is not the visual part of it. Also you see that the experimental group significantly more decreases the suicidal ideation than in the control group. So about suicidal ideation and suicidal intrusions, the treatment is very effective, also compared to a control condition of treatment as usual. About depressive symptoms, you can see that the depressive symptoms go down as well, but they also go down as well in the control condition. The results, we did a study with a light on a bulb, a light bulb on a bar. So not with fingers, but with a light bulb. So it was standardized for all patients in the same distance and the same speed. After 3 months, half of the participants had no intrusions left at all. So in the mean of 4 sessions, which is quite short, I think, so quite spectacular, because we had also participants who had these intrusions for many months, many years, 10, 20, 30 times a day, and now they just had none left, which is a spectacular result. In my private practice also 70 suicidal patients treated, only 1 patient did not respond to the EMDR. What do patients notice after EMDR? They say, well, this future disaster, I must admit, it's only a representation in my head, it's only an image, that's all. It's no reality, it's a risk, it's a chance, but it's not reality, it's not there, it's not imminent. The image of the suicide becomes smaller, further away, more neutral. I regularly see that patients become confused. They are just in no time doing a kind of rational, emotive, cognitive change, as if the chaos vanishes. And they say, well, I don't have to do what I don't want to do. Why should I do something I don't want to do? I do have some control of myself. I have control of myself. They just experience, they feel the control of themselves. And also there's a kind of self-reflection. I cannot do this to my near and dear. But also I don't have to be afraid of images, since I'm not getting to commit suicide anyway, which is totally different than perhaps a half hour previously. And sometimes you see a deep state of self-reflection showing up, people understanding what am I doing? What drives me crazy? So the conclusion is a slightly truncated version of EMDR, so without installing a positive cognition, which is always I can look at it, is effective in the treatment of suicidal intrusions. This treatment is safe, effective, quick and easy. We had no adverse incidents in the study, not at all. So this is truly an international breakthrough. I thank you for your attention.